Thank you for joining us for this interactive Facebook Live event presented by Siteman Cancer Center based at Barnes Jewish Hospital and Washington University School of Medicine in St. Louis. Siteman is an international leader in cancer treatment, research, prevention, and education. Ranked among the top cancer centers by U.S. News and World Report, Siteman also is one of only a few U.S. cancer centers to receive the highest rating of exceptional from the National Cancer Institute. Welcome to today's Facebook Live.
Hello, and thank you for joining us today for this Facebook Live presentation presented by Siteman Cancer Center, which is based at Barnes Jewish Hospital and Washington University School of Medicine in St. Louis. Today, we're going to be discussing one of the latest frontiers in cancer care, which are cellular therapies, including CAR T-cell therapies. And we have with us two experts who are Washington University physicians who treat patients at Siteman Cancer Center, and also our researchers here. I want to introduce to my immediate right first Dr. Armin Ghobadi, who is an associate professor of medicine and also a clinical director of the Center for Gene and Cellular Immunotherapy at WashU and Siteman. So thank you, Dr. Ghobadi, for being here.
Thank you.
And to his right, we have Dr. Amanda Cashen, who is a professor of medicine and a treating physician at the Center for Gene and Cellular Therapy. So Dr. Cashen, thank you also for being here today.
Thank you.
And I want to welcome our viewers again and to invite you during this live event to write your questions in the comment section on the page for our experts to answer here in a little bit. And Dr. Ghobadi, I wanted to start with you first by asking if you'd explain what cellular therapies are. It sounds like an exciting frontier, but what exactly do they do? And how do they differ from more traditional forms of cancer therapy?
So just a little bit of a background in patients with cancer, immune cells cannot see the cancer cells and get rid of them the way that they get rid of infected cells or infections, because cancer cells camouflage from our immune cells. So the main cornerstones of all these cellular therapies teaching the immune cells to see the cancer cells as bad again and convert them to cancer-killing machines, really.
Okay.
That's the main corner of it, and we do this in different ways.
I've heard a number of different analogies for cellular therapies, and you sort of described one there. It's sort of like training your own body to fight the intruders that are cancer cells. Is that correct?
Exactly.
Well, that's certainly an exciting frontier. I mean, I guess, how does that differ then from more traditional forms? You know, medical oncology or chemo. You know, radiation oncology is another form as well.
This is considered one of the newer pillars of basically cancer therapy. Chemotherapy, surgery, and radiations have been the three mainstay of treatment for cancer, and are still remaining three mainstay of cancer treatment. This is our pillars, and this is the newer pillars. Like 70 years ago, when penicillin was invented and changed the way that we treat infections in general, this is basically a new frontier, a new way of treating cancer using, as you mentioned, our own immune cells, patient own immune cells, to get rid of the cancer cells. This is a wave that has started and is going to change dramatically the way that we treat cancer. It's already a start, and we're gonna see a significant, more dramatic changes in the near future, I believe.
I guess in my mind, I sort of liken it to adding a fourth leg to a stool, right?
Exactly.
So you have the three traditional forms of cancer care, but you're adding a fourth one, which really allows you to personalize the treatment for each individual even more so than maybe in the past.
Exactly.
Very good.
Exactly.
Well, sort of to that point, I know that you treat patients with leukemia and lymphoma. How do you determine what treatment or what combinations of treatments are best for each individual?
So when we treat patients with leukemia and lymphoma, and also we have CAR T-cell therapy and neuroimmunotherapies for multiple myeloma as well. So when we treat patients, usually at the beginning, especially for leukemia and lymphoma, around 40 to 60% of the time we can cure with the traditional chemotherapy regimens that we have. But what happens, cancer's coming back in a fair number of our patients. And when they are coming back and they are not responding to chemotherapy, then in those situations, we are dealing with the really irreversible cancers that chemotherapy only cannot reverse the course of cancer and cure the patients. And that's where this new cellular therapies like CAR T cells are come in play and help our patients. Just an example, when you have a patient with lymphoma that is not responding to chemotherapy, if you use just chemotherapy, more chemotherapy, that's not going to work. And usually people can't survive more than a few months when you're dealing with that situation if you just use chemotherapy. But when we use some like CAR T cells, that even approved CAR T ones, chance of response to them is as high as 80 to 90%. Wow. And for a disease, for a cancer that is considered incurable with chemotherapy, around 35 to 40% of them can be cured with CAR T. So that's a dramatic change, really.
That's amazing. I sort of see it as a plan B, maybe even a plan C sometimes, so that if the first therapy stops working or isn't as effective as it used to be, then you have another line of defense that you can work on with the patient.
Exactly.
Certainly exciting news to hear. And I also wanted to invite back Dr. Amanda Cashen, who's a bone marrow transplant specialist at WashU and Siteman, and I understand that you specialize in lymphoma, leukemia, and myelodysplastic syndromes. Is that correct?
Yes, that's right.
Well, thank you again for being here. As we know, some of our viewers have heard of CAR T-cell therapy. Others maybe have not. It's, of course, a type of therapy that received federal approval, I believe, in 2017. And Siteman and WashU were one of the first cancer centers in the nation to offer that therapy that Dr. Ghobadi just described. And can you kind of tell us how, since 2017, when it first was approved, it's sort of evolved and what that therapy looks like today?
Yeah, it's been so exciting to be part of the development of the CAR T-cell therapies for the lymphomas and some of the leukemias. We were involved in the earliest trials at Siteman Cancer Center, and we're one of the first places in the country to have it available once it did get FDA approval. So the CAR T-cell therapy is using the particular component of the immune system called T cells to fight the cancer. So we collect the patient's own T cells from their blood, and then those are sent to the lab where genetic strategies are used to re-engineer the T cells so that they express a new receptor on their surface. That's the CAR, the chimeric antigen receptor. And then those cells are returned to the patient, infused into their blood, and now they have this receptor that will find one of the markers on the cancer cells and target the T cells to the cancer cells, setting off this immune system reaction that brings the full force of the immune system to eliminate the cancer cells. So what's changed over time is first of all how we've managed the patients. That immune system reaction can be so powerful that it can make a patient really quite sick. And so I've been really pleased to see the dramatic improvements we've made in managing patients safely through this therapy. We have much better tools now to control the immune system response and treat the side effects so that it's safer and we can offer it to more patients and older patients than we were doing at the beginning. And then we've also found more types of lymphomas in particular that are susceptible to this treatment so that we can offer it to more patients.
Obviously, as with any treatment, you sort of fine-tune it as it goes along, and you can find new, better ways of treating people with it.
Exactly.
And CAR T and cellular therapies are obviously fantastic, but one of the cellular therapies I also wanted to talk about is the bone marrow transplant that you're also using to treat patients. Now, WashU's been offering that since the 1980s, so it's a more, maybe a more traditional cellular therapy, but certainly something that's still a type that still shows promise and saves people's lives and is very much remains effective. Can you talk about how you decide whether a candidate is a good patient for stem cell transplant or a CAR T or another maybe more more modern type of therapy.
Yeah, you're right that stem cell transplant, bone marrow transplant still has an important role to treat many of our patients. That was really the original immunotherapy. It's just in that setting we take another patient, another person, a donor immune system to fight the cancer. And so that's still a very important treatment, partly because CAR T cells are only approved and developed to treat certain kinds of lymphomas and leukemias. So, for instance, acute myeloid leukemia, which is the most common leukemia in adults, does not have a standard CAR T cell option at this point. And so if those patients need a kind of immune system attack against their leukemia, we need to turn to a donor for a transplant.
Very good. And I wanted to turn to Dr. Ghobadi and ask him, I know that, while bone marrow transplants have been around since the 80s or so, we've also advanced the work there and the research there, including who can be a good donor for a patient. Can you talk about some of the work that's taken place here with that?
So just to add to what Dr. Cashen mentioned, a stem cell transplant was the original and the first cellular therapy to treat cancers. And since 1980s, we have grown to one of the largest transplant center in the world under leadership of Dr. DiPerzio and Dr. Westerwell here. So we still offer that treatment to our patient, and it still is a mainstay of treatment for a large number of patients with cancer. The main components of a transplant is still chemotherapy and radiation. So if the patient doesn't respond to chemotherapy, then transplant is not going to work, and that's the main difference here. So we think that they're not going to be competitor transplant and neurocellular therapy. More of they're going to have a complementary roles. Each they're going to have their own basically a spot in treatment of patient with cancer, especially blood cancers, and as I mentioned, this is one of the our centers, one of the more advanced, largest transplant center in the world. And one component of transplant, for example, is collection of stem cells. And one of the treatment or one of the medication that we use for collection of stem cells actually was done based on a research that was done at Washington University in Dr. DiPerzio lab. So there's there are researchers, scientists here that work deeply and fighting side effects of a stem cell transplant. The main side effect, that's the graft versus host disease.
So it's sort of a comprehensive overview, not only offering the treatments, but also researching the treatment of symptoms, maybe future therapies as well.
Exactly. So absolutely. There's a combination of clinical and also advancing the field as one of the largest and premier centers for treatment of cancer. So when we use CAR T cells and newer, more advanced cellular therapies like CAR T or TCR T cells or NK cells or tumor infiltrating lymphocytes, those are a platform of newer, more advanced cellular therapies. The main difference between this newer, more advanced cellular therapy compared with this stem cell transplant is the more focus is on actual cells killing the cancer cells. So there is no reliance on chemotherapy or radiation when we use it. So that's the main difference between the newer cellular therapy and a stem cell transplant that we use. The newer cellular therapies are more targeted, more precise, and more personal. And in majority of times, actually less toxic.
Yeah, I was going to ask about that. Does that mean that patients have fewer symptoms if their own immune system is fighting the cancer?
Yes. So still we are dealing with the newer cellular therapies like CAR T cells, as I mentioned, are extremely effective, but still we are dealing with the side effects, and that's why you need to be in a center with really good experience with management of those toxicity and taking you through the aftermath of getting those effective treatments. But if you overall compare some newer cellular therapy with something like allogeneic transplant, the chance of side effect is significantly less compared with the donor transplant.
Very good. And I assume one of the benefits to patients is when they come to a center that sees a lot of patients in need of these therapies, the expertise is there to differentiate between different types of cancer and also what the most effective therapies are.
Absolutely. Basically, the whole idea of having the experience to take you through the management of them. There are a lot of details in terms of when you're getting this cellular therapy, side effect can happen, and how you manage that, the way that you prevent the side effect causing trouble, but living and letting those living drugs doing their job.
Very good.
So finding that sweet spot.
And I wanted to talk to Dr. Cashen about this. I mean, it's always exciting to talk about the next therapy in cancer care, and certainly CAR T is that, right? But I also think it's important to highlight the advances that have been made in bone marrow transplant. And I know the types of people who can donate sometimes are issues, but we've also done work into that area as well to help make those stem cell transplants more effective. Can you tell us more about that?
Yeah, exactly. The stem cell transplant from a donor, allogeneic stem cell transplant is the term we use for that, is such a important, potentially life-saving therapy for many patients with leukemias and lymphomas as a complement to these cellular therapy options. But not every patient has a matched donor, which has always been a limitation of the transplant therapy. But now we have a lot more flexibility in the donor choices because we can use donors who are half-matched, which opens up the options for parents, children, more siblings, even cousins sometimes. And a lot of that research to make those half-matched transplants work and be safe has happened here at Washington University and Simon Cancer Center.
Again, kind of reinforcing that comprehensive look at both treatments and research. Now, Dr. Ghobadi, I know that you're heavily involved and your teams with research in these areas. Can you kind of talk about what you're working on now and where you sort of see that work going in the future?
So at Center for Gene and Cellular Immunotherapy, we really have one main mission. And the mission is to bring the most advanced, effective cellular therapy to our patient in this region. And we do this through the three different, basically, strategies or ways. One is when there is approved effective cellular therapy, we want to, and we have always been one of the first centers to have access to those and bring those to our patient in the region. So that's one. And two, develop advanced effective cellular therapies, investigator-initiated here by our physician scientists or in collaboration with a big pharmaceutical company, bring in cellular therapy trials, more advanced, effective, the one that we think is going to be really is going to help our patient to our center and for our patient in this region. We're opening really clinical trial and developing clinical trial here. And the third way of doing this is actually working. There are several working in our labs. There are several labs that are heavily engaged in developing newer cellular therapies and also helping on finding ways to make them less toxic. And that's also one way that we have been engaged. Several labs, including like Dr. DiPerzio lab and Dr. Feniger lab, have been heavily engaged in developing the really newer cellular therapies. And cellular therapies that develop, the basic science of those were done here at WashU are common in the clinic. We already have clinical trial using those cellular therapies and actually opening cellular trials that we're using more of those cellular therapies in the near future. So one example, for example, we are opening off-the-shelf CAR T-cells for T-cell lymphomas that, just few centers in the world have access to such a thing. There's for patients with T-cell lymphoma, there is not much, there is no approved CAR T-cell for those type of lymphomas and leukemias. And this is based on a research that was done and a cellular therapy that was developed in Dr. DiPerzio lab here. And that is, we are very close to open a clinical trial and offer that option. And it's off the shelf. That's also is very exciting that we don't have to go through the manufacturing and waiting a few weeks to make it.
So you can deliver the therapy more quickly.
Exactly. And to add one other thing, so just only a few centers really in the world have a capability of manufacturing CAR T-cells. So for the first time, actually, in late 2020, we started manufacturing CAR T-cell here at WashU and Simon Cancer Center. And we're able to offer that to our patients so that basically we're able to manufacture it and give the CAR T-cell fresh rather than frozen, and shorten the time from seeing the patient to giving the cells significantly.
I mean, when you talk about personalized care, that's a component that really makes it so, isn't it?
Absolutely.
And again, it reduces the treatment time or the time between diagnosis and beginning of treatment. And generally, I mean, there's no downside to
Absolutely.
that. And
Absolutely.
not many places can do it, I understand.
Absolutely.
Now, Dr. Cashen, we were kind of talking earlier about how, right now most of these CAR T-cell therapies are for blood and bone marrow type cancers, but we're already looking at how this might be used for solid tumors. I know that's not your, your subspecialty, but what can you tell us about where this might head in the future with other types of cancer?
Yeah, it's been really exciting to see the principles of cellular therapy and the success of cellular therapy that started in lymphomas and leukemias start to spread to other cancers because, of course, there's so many patients who could benefit from this therapy. So it takes devising different ways to train the T cells to identify the cancer cells. They need to identify different targets and for different cancer types. But we've been really at the leading edge of many of those trials as well. And even though those cancer types weren't my specialty, I think Dr. Ghobadi and I both are getting used to seeing them more often because we have to collaborate with our colleagues who do specialize in those other cancer types because it's still going to be our team with our expertise in the cellular therapies delivering those treatments.
Well, it's wonderful news to hear that something that works so well in one area will also help patients with other types of cancers as well.
Yeah, we're very optimistic about the initial things that we're seeing in clinical trials and hopeful for a lot more advances in the time to come.
I love hearing it. I wanted to also mention, there are people out there who have been not newly diagnosed with leukemia, lymphoma, maybe another type of cancer, and maybe they understand half of what you guys are experts in, right? But what sort of advice do you offer to people who maybe don't know what to do next? They're in that stage where they know that they have cancer, but they don't really know what their treatment options are. What do you say to patients who are in that place?
Well, it is a complex decision about devising the best treatment for any given patient, whether it's at the initial diagnosis or the time of relapse. There's so many effective therapies for leukemias and lymphomas, including the cellular therapies and transplant, but still are very effective chemotherapy treatments. And so devising the right treatment plan for a given patient is challenging, and I certainly recommend to patients to seek out experts in the type of cancer that they have so that they're sure to be getting the state-of-the-art treatment and the best plan for them.
Thank you. Actually, we have some questions here from viewers, and Jen was asking something along those lines, and she says, what other resources are available out there for me to learn more on this topic and send to a loved one who's currently battling leukemia? And Dr. Ghobadi, I know you mentioned earlier that you have a website that people could use for information and resources as well.
Yes, we have created the website cgci.wustl.edu, and one significant component of that is patient education. So there's a patient education tab over there. That there are some educational videos, very nice educational videos over there, talk about the options and links to more resources for patients who have cancer or people that they have a loved one with cancer.
And you also mentioned that there are a number of, you mentioned clinical trials already, but is there information on the website about clinical trials as well?
Yes, so that website we have linked to cellular therapy trials, and we have more than 25 clinical trials actually right now for cellular therapy clinical trial for not blood cancers, for solid tumors like lung cancer, sarcoma, liver cancer. We have cellular therapy for all of those malignancies, and we have a link to those clinical trials on our website.
Very good. Now, I know, a lot of people know what clinical trials are, but for the benefit of those who don't, could you describe what that is and how it benefits a patient looking for a treatment?
So when we are dealing with the cancer that we don't have really a standard treatment that can reverse the course of that cancer, we obviously researchers here and around the world working on finding new ways to treat those cancers. And when that happens, so there are new treatments that are not still approved by regulatory bodies like FDA for those cancers. So you have to go through clinical trial and show that they are safe and they are effective. And so there is a product, specific cellular therapy product, that based on the preclinical data on what is done in the lab, we know that has a lot of promise in it. And then we can bring that in a setting of a clinical trial for patients that really don't have any other options available in the setting of a standard treatment.
Okay, very good. That kind of dovetails into a question from another viewer named Julie, who's wondering what will it take for CAR T to be investigated for other cancer types, particularly rare cancer types? And I assume that would start with a clinical trial as well?
Exactly. So it's so if you look at the number of clinical trials that were using cellular therapy, in 2011, 10-11, there were 500 to 700 clinical trials worldwide, majority of them in U.S. When I just checked a couple of months ago, the number was up to 2,100.
Wow.
And that is going up dramatically, and not only for broad cancers, is for all type of solid tumors and other cancers. So I think this is a wave. We know this cellular therapies, including CAR T, has already changed the way that we treat blood cancers. But I'm hopeful that in the near future, this is actually a combination of this cellular therapy with more targeted therapy, like oral agents, even chemotherapies, and T-cell redirectors, and some mild form of chemotherapy is going to dramatically change the way that we treat other type of cancers and hopefully convert some of this deadly incurable one to curable ones. I'm hopeful that that's going to happen. And when we deal, so that's obviously was a proof of concept. No, we have 5 CAR T cells approved for blood cancers. This is just the start of it. Like when penicillin was invented 7 years ago, and we have hundreds of antibiotics now. This is just the start of it. Researchers here and around the world looking at other cancer, finding you need to have a specific target, finding better targets, so to expand using this platform for other malignancies and also making them safer.
Certainly exciting to be on the frontier of something so new and something that's so promising. And I know that you've put a lot of your thought and your expertise into a book that you and Dr. DiPerzio have both been working on. Could you tell us a little bit about that?
This cellular therapy and gene and cellular therapy that include a new platform or pillar for treatment of cancer include a large number of newer subtypes of cellular therapy that we couldn't find actually when we have students or trainees and other people are asking, is there a book that combine all of those in one volume that I can read or give it to our student? And it wasn't such a thing. So about 1.5, 2 years ago, we decided to actually write and edit this book that review all of those, put all of those, the most advanced cellular therapy and T-cell redirected therapies in one volume that include CAR T, T-cell receptor directed T-cell therapy, viral CTLs, NK cells, and tumor infiltrating lymphocyte, and also T-cell engager. Those are all most advanced, really, cellular therapy in one volume. And it's going to be out, the print of it is going to be out in the next few weeks, and hopefully a lot of people are going to find it exciting and informative.
Well, that is exciting. I mean, literally, if the book does not exist, you know how advanced this therapy is, right? Exactly. If it needed to be written.
Exactly.
And I think we'll put a link in the comments section for people to see where that book is.
Awesome.
I believe it's coming out next month.
Awesome.
We also talked about, other types of tumors here, Dr. Cashen, where we're really sort of at the frontier of treatment when it comes to CAR T. And we have a question here from a viewer named Nadia, who's wondering about CAR T-cell therapy for sarcomas. Is there anything on that frontier that you have to share?
Yes, we've been really at the forefront of the T-cell therapies for sarcoma at Siteman Cancer Center, one of the biggest enroller on the sarcoma trials that have led to a lot of promising outcomes for those patients. So we collaborate closely with our colleagues who see the sarcoma patients at Siteman Cancer Center to offer those therapies currently in the context of a clinical trial, but we are hopeful that there'll be FDA approval and wider availability of that treatment even off of trials coming up.
And then again, Siteman and Wash has that history of being one of the first to offer these types of therapies, and hopefully that would be the case with newer ones for sarcoma as well. Dr. Ghobadi, we have a question here from John who's asking if CRISPR-Cas9 or Cas9 perhaps, the technology used in that, in the gene editing, is also used in CAR T. Obviously, this is someone who knows a little bit about the topic himself.
Absolutely. So the one that actually, that's a very good question. So the one, so maybe a little bit of a background. So when we use CAR T cells, we take patients' own T cells out and change it the way with adding a gene that can make chimeric antigen receptor on the surface of it, that using patient's own T cells. So when we do this, we have to take the T cells out, send it to the lab, and manufacture CAR T. This takes around 3 to 4 weeks. And that can be a delay, and cancer obviously doesn't stop when you're making the cells. So the newer platform is going to be using a T cells that is, or a CAR T that is off the shelf, that basically you can give it to the patient right away when they need it. So that means you have to use somebody else's T cells and make it CAR T for that patient. So when you use somebody else's T cell, that can cause trouble. So with using this newer gene editing strategy like CRISPR-Cas9, you can change another person's T cells the way that cannot cause trouble when you give it to a third person. And that has been a significant help. The first actually CD7 CAR or universal CAR that was developed in Dr. DiPerzio lab, that one is using the same technology to make the off-the-shelf CAR T cells with patient with T-cell malignancies.
Well, it's clear why you wrote the book on the topic, so we appreciate you sharing your knowledge.
welcome.
We have run out of viewer questions, and so I wanted to thank each of you for being here today and sharing your knowledge with our viewers. And obviously, we want to thank our viewers as well for joining us. And we'd like to remind you to follow Siteman's Facebook page for future Facebook Live events like this. Thank you again for joining us today.